right place. It is 7 p.m. Central Standard Time here in Chicago, and you are watching a joint live stream. Medicine Makers is the television show that a lot of you know that I am on. It is put on by the I Am Able Foundation. And due to the COVID-19 pandemic, the television station is currently closed. So the founder and CEO of the I Am Able Foundation, who's actually one of my guests tonight, had a great idea and said, let's just bring Medicine Makers to the live stream audience. So here we are. I just wanted to welcome everyone. We're going to give people a chance to get settled in. What I would love for you to do, because it's Friday, we made it to the weekend, y'all. We made it through another week. I would love for you all to chime in and let us know where you are watching from before we get started with our live stream tonight. Oh, all right, we got a guest here, Stephanie. Okay, so all of you guys know Stephanie is my sister. Okay, Stephanie, type in where you're coming from. Where are you watching from? And thank you so much for joining us tonight. I appreciate that. All right, and Stephanie, if you can, let us know if you can hear us okay. Okay. All right. She's from Tampa, Florida. All right, sunny Florida. Okay, well, that's awesome. Thank you so much for tuning in. We've got the lovely Dr. Parker. Oops, I told everyone you're a doctor. I hope that's okay. She is also my bestie from medical school. She is coming from Brooklyn. All right. All right. Can you guys hear us okay? Hopefully you give us a thumbs up if you can. So for those of you that don't know, this is the lovely thing about a crisis, because it teaches you to improvise and get really good with some things that you may have never done before. So I am actually, this is my very first joint live stream. Normally when you guys see me on Facebook, I'm just here by myself. And today you are in for a lovely treat. We have two of Chicago's finest medical doctors here with us. I mean, it would take us like probably 20 minutes to go through all of their introductions, but we're going to go ahead and get started. People can just jump in. If you know someone that should be watching this live stream, by all means, please share it. Send them a text message real quick and have them jump in and watch us, okay? So for those of you that don't know me, I am Dr. Rene Roberts. I am board certified in family medicine. I am also a mentor with the I Am Able Foundation. We're going to hear a little bit about that tonight. And two of the lovely ladies that are with me tonight are also a part of the I Am Able Foundation. We have the lovely Dr. LaMenta, Sweetie Conway. Folks, this is the founder and CEO of the I Am Able Foundation. So we'll give her a chance to speak in just a second. She can tell you about that. And we also have the lovely Dr. Toyin Adeyemi. She is an infectious disease specialist here in Chicago. She was actually on Mayor Lori Lightfoot's, I believe, briefing just this past Monday. So you guys, we have some celebrities in the house. Okay, well, let's go ahead and get started with our introductions. Dr. Conway, why don't we start with you first? You can say hi to our audience.
Well, hello, everyone. As Dr. Rene mentioned, I'm founder and executive director of I Am Able Foundation, which is a nonprofit 501c3 Chicago-based organization devoted to Chicago area kids. And what is our purpose? To raise our next generation of healthcare heroes. I feel very honored and humbled to be on a panel this evening with the likes of our executive producer and host, Dr. Rene Roberts, and also my friend for over 20 years, Dr. Toyin Adeyemi. And we met as kiddos once upon a time at the University of Illinois, and she was my chief resident. And I'm just so thankful for the relationships that God has allowed us to maintain and build over these years. Another thing that I'm proud of is that all three ladies that are here tonight are board members of I Am Able Foundation, and have been pivotal in moving the organization to where it is. Well, these are strange and unusual times that we're living in.
Yes.
And when I speak to our young people, I told them, I said, okay, this is where the rubber meets the road. Now you know what doctors are really doing. We've never been challenged in the way that we're challenged today. We always thought life was hard, being a doctor. We thought it was hard until today. Now it is life and death. And I think our kids get a chance to see that up close and personal. And they do feel helpless in some ways. But as we just finished our recruiting season, we have over 60 brand new kids. The organization is growing leaps and bounds. I'm doing my best to keep the kids encouraged, because by now we would be having our Chicago Health and Medical Careers Citywide Student Conference. We'll be getting ready for the gala. In fact, on this coming Saturday, or in one more week, we would actually be over at Cook County doing our simulation for CPR. And it's so exciting. And this is the biggest, probably one of the strongest, academically at least, groups that we've ever had, because it grows and expands over the years. And we're getting off to a funky start, but I do know that God has some great things in store for us if we're patient. And if we trust the process. This kind of pandemic has a way of bringing out either the best or the worst, but I am trusting that it's going to bring out the best. In my professional life, outside of the foundation, I'm Deputy Chief of Medicine for the Illinois Department of Corrections. And of course, through all of the prison and jail systems throughout the country, we are all challenged like we are challenged within the community. But I remain optimistic and hopeful, and again, trusting the process that we're going to all get through this. Maybe not unscathed, but we will be better and stronger because of it. So thank you for having me on Medicine Makers. In fact, there are 3 hosts here too. We've all hosted the show before. And we're thankful for
we have
as executive producer and taking us to another level. So great to be here on the panel with you.
Oh, fantastic. Thank you so much, Dr. Conway. And of course, I always plug the foundation. I absolutely love I Am Able. And Dr. Conway knows my story. I think Dr. Toyin knows my story too. I wish I had something like I Am Able. I would not have struggled nearly as much as I did in medical school, but the struggle was for a reason. And now I'm able to share my story with the high school, college, and post-bac students that participate in the I Am Able Foundation, so they don't have to make the mistakes that I did, but I'm still here. So fantastic. Thank you so much. Okay. All right, everyone. Our next dynamic doctor that is in our virtual house call tonight is the lovely Dr. Toyin Adeyemi. I hope I did not mispronounce that. Ladies and gentlemen, you guys have a wealth of knowledge at your disposal tonight. Dr. Adeyemi is a infectious disease specialist. So, honey, this is right up her alley with all this coronavirus. Welcome, Dr. Toyin.
Yes, thank you for having me. And we have such great content we want to get through today. So again, I'm happy to be here. Thank you for having me. It's great to be a member of I Am Able Foundation. And again, like Dr. Conway talked about, it becomes really important as we talk about raising that next generation of healthcare heroes and finding a trusted source of information, that organizations like this are very important. An infectious disease been in practice for over 20 years. And Dr. Conway and I met, 25 years ago, actually, 1995. And
we were back.
Yeah, right? Happy to be here to really talk about some sobering things that are going on, to get some information out there, to exchange, answer questions, but also to leave with kind of some action items and steps and things we can do during these times and post-COVID, because some of the issues we're going to talk about have been in existence for a long time. This has amplified them. So I'm really happy to be part of this conversation to talk about really critical things at this time. So thank you for having me.
Fantastic. Okay. So ladies and gentlemen, we have 2 fantastic doctors with us. This is your opportunity to ask as many questions as you like. We'll do the best that we can. I obviously don't want to keep these ladies here all night, but start thinking about your questions now, or any comments you have, obviously, our world has been turned upside down this past month. Who would have ever thought that we'd all be sitting in the middle of a pandemic? The last pandemic that I know that hit the world as we know it was 1918, the Spanish flu, and now we are presented with the coronavirus. I'm pretty sure those of us that are in healthcare kind of remember studying this. I had to do a flashback to microbiology there for a second, but just a quick recap. So. Usually, and correct me if I'm wrong, Dr. Toyin, I know coronaviruses usually did not infect humans. I watched a very interesting documentary that 60 Minutes in Australia did talking about wet markets. I don't know if you guys have heard that term before. And wet markets are essentially areas very popular in many Asian countries, but in this particular area of China, Wuhan, China, where people go to buy and sell exotic animals. So unfortunately, these little animals are caught from all over the world, Africa, South America, the Middle East, what have you. And many of these animals are kept in very close confines, animals that normally would not interact with one another. And so it is believed, again, that the coronavirus began in what we call like a vector-host relationship, possibly a bat, and then the bat somehow came in contact with this animal called a pangolin. Kind of looks like a little baby armadillo. And pangolins are known to have healing properties. So they are actually purchased, highly sought after, and also consumed and eaten. And so one of the interesting points that I thought was brought up in that 60 Minutes piece is that, you know, the animals very much could have been under a lot of stress being out of their natural environment that can weaken their immune system. And maybe that is what made them more susceptible to getting the coronavirus. And then if someone were to consume that pangolin, therefore ingested inside a human body, and then the virus set up shop, and the rest is now history. So Dr. Toyin, why don't we start with you? Since you are the infectious disease specialist, I know you just had a press conference with Mayor Lori Lightfoot here in Chicago. What would you like our audience to know about coronavirus? I know that's a very broad question.
Really,
I mean, hey,
right.
what do you want us to know?
Really
Yes.
broad question. So it's important to know that there are hundreds and hundreds of coronaviruses that infect, you know, humans and different kinds of animals. We call this the novel coronavirus, or SARS, you know, SARS-CoV-2, because it was similar to the SARS-CoV virus from a decade ago. Because this new one, this novel virus, is thought to have come directly in contact with humans in late December of 2019, and that's why it's called COVID-19, because it was, like you described, circulating in animals and then transferred to humans. So while we have coronaviruses that have been around that infect humans, usually cause mild illness, upper respiratory tract infection, common cold, this novel one, because it transferred from animals to humans, we had no native immunity to it. We hadn't seen it, so we had no antibodies to it. It's attacking us, you know, very contagious and also causing more damage because we have no herd immunity to it. We don't have people who've been exposed to it. We don't have vaccines for it. So, and that's why, but again, discovered, you know, first clinical cases in 2019, and then declared a pandemic a couple of weeks ago by the WHO, because we have it in over 200 countries now, and, you know, over 1.6 million people as of today who have been diagnosed with this coronavirus or COVID-19. And so what we know about it is that the first couple of cases, you know, I think the first death from this virus wasn't until, like, at least reported, right, in January, and it took about, you know, almost 3 months to get to 50,000 cases. And then right after that, things have just been growing exponentially. So very highly contagious virus. What we know about it is that it's spread usually by droplets, so respiratory droplets from coughing, sneezing. Now we know from heavy breathing, mouth breathing, sometimes even from forceful talking, whatever that means. We know that it can stay in the air a little longer than we thought with some aerosols. We know it's also spread by what we call fomites, where when it's landing on surfaces and people touch surfaces that have the virus and then touch their face and mouth and nose and eyes, they can get the virus that way. And the main thing is that, it's thought that more than 80% of people will have a mild illness, mild, moderate illness, ill with flu-like symptoms. But then 20% can go on to very serious disease, and serious disease causing pneumonia, hospitalization, and unfortunately, death. And one of the things that we're seeing, and which I know we'll get to, is the disparities that we're seeing in African Americans and Hispanics in terms of deaths, infections, and deaths from COVID-19. So novel to humans, very contagious, and spread very widely and rapidly to over 200 countries. Where we are in Illinois, we have over 500 people who have died of this here in Illinois. And we know that right now, there is no cure. There are some treatments that are being looked at, and the biggest part is prevention. I'm really talking about prevention. So that's kind of a little summary, and I know we'll go into more detail as questions come up.
Okay, thank you so much for that. So I know there are a lot of people out there that are obviously still a little on edge. There's a lot of talk this week. I know we're going to get to this about the story that broke about some healthcare disparities, and Dr. Conway is going to definitely be touching on that as well. But what is this whole concept about pre-existing conditions? There were particular, like a set of like 3 or 4 conditions in particular that if you had these other health conditions, put you, I guess, at a higher risk for having, a harder time with the coronavirus if you were to get it. Comment on that.
So did you want me or Dr. Conway? It's frozen. Hello?
I think we might be frozen.
Okay, now we're back on.
Yes. Uh-oh. Just one second, everyone. We got some technical
Dr.
difficulties.
Toyin, you can go for it.
Going on.
All right.
My screen is actually frozen.
Okay. So like you brought up, Dr. Rene, the disparities in terms of outcomes we're seeing.
Move here.
And we're seeing that certain conditions increase your risk of having a bad outcome, requiring hospitalization, having to be on the ventilator, and dying from this. And those are things we call comorbidities. Things like diabetes is a big one, hypertension, heart disease, lung disease, COPD, asthma, and obesity. Those are things that are seen that in every case, when we looked at the numbers of people who died in Chicago area, when they looked at the cases that were first presented, 9 out of 10, more than 97% had at least one of these pre-existing conditions. So, diabetes keeps coming up over and over, high blood pressure, heart disease, all of those things are linked together. Smoking, right? So smokers seem to have a harder time. And then in addition to that, but obesity in the US has become a real big risk factor. So when we were looking at all the data that was presented initially from China, from Iran, from Italy, they were looking at deaths, and we saw a big increase in deaths just from age was the biggest one. And then it moved into the United States, and we started to see it in younger people too, people in their 20s, 30s, 40s. And one thing that is coming out from those of people in the hospitals, in the intensive care units, in the emergency rooms is that obesity is a risk factor that is huge. It's making people get on the ventilator. It's making it a hard time to ventilate them. They're having a high outcome, bad outcome. So those things all cluster. And Dr. Conway's been talking about this for years, for decades, the importance of primary care and primary prevention, because all of those things are more common. They're happening at a higher frequency in communities of color. And then you add on this virus. And one of the things we talk about with health disparities, and I know Dr. Conway will go into more detail, is that we've known that these disparities have been around for a long time. Why are we hearing about this now? Because the deaths from COVID are happening quickly. When people get sick, within days or weeks, if they're going to have a bad outcome, they're dying of it. So we're seeing those disparities happen much earlier than we know for what we see for asthma and high blood pressure and diabetes and cancer and all those disparities. And we can talk a little bit more later about why that is happening, the disparities, but higher rates of these pre-existing conditions, smoking, obesity, diabetes, and then add on a viral infection that attacks the lungs, and access to care and a whole bunch of things. And the last part, just in Chicago, 70% of the people who died from COVID in Chicago, 70, were Black. 70%. And of that, those people, 97% had a pre-existing condition. So we can talk a bit more about that. And they're repeating that. They've seen that in Milwaukee. They've seen that in Detroit. They've seen that in Cleveland. They've seen that in New York, in urban areas. We're seeing this huge disparity in outcomes.
Very much so. We have our first question. Noel has asked, and I think Dr. Conway will direct this towards you. Noel asked, should we be using a mask every time we go out? I know there's a little bit of a delay for Dr. Conway, so. Mm-hmm.
I apologize if there is a delay because I'm having some technical difficulties over here.
Okay. That's okay.
But I'm just going to keep talking. Hopefully we can catch up. But I know the question is, should you be wearing a mask? And the answer is, yes, you should be wearing a mask. Hold on one quick second. So yes, you should be wearing a mask. It helps from two perspectives. The CDC calls it source control. And what we're trying to do is to control the source of infection. So by wearing a mask and assuming that you have it, whether we know you do or not, we know that testing is not widely available. So the assumption is that you have it. You have to think of it that way. And if you had it, what would you do to protect everyone else? So what you would do is you would wear a mask. So yes, you should be wearing a mask. Now, if you were actually literally exposed to COVID, how well would that mask work to protect you? I mean, it is a barrier, and any barrier is helpful. If you were in the throes or directly exposed to COVID, will it be the best? You know, your do-it-yourself mask, would it be the best one? Probably not, but any barrier would help. One thing I want to encourage people to do is when you have a do-it-yourself mask, have 2 or 3 of them at least, so that you can recycle them and that you can recirculate them. And it's very important when you're wearing your do-it-yourself mask that you don't keep touching your face. We're going to have to retrain ourselves not to touch the mask, because the assumption is if you're wearing this mask and you happen to walk into a germ cloud of someone else's, you don't want to start touching your mask, and then subsequently when you take it off, then you're touching your nose, your mouth, and then you still ended up get it infected. So while you're wearing your do-it-yourself mask, the other thing I want to encourage everyone to do, and when should you wear it? Do you need to wear it in the house? Probably not. If you don't have a very sick or immunocompromised person in the home that you're trying to protect, the assumption is probably the people in the house probably have the same thing. It's kind of hard to avoid spreading it within the house. But if there is someone in your house that is very elder, and you don't know your status and we don't know their status, you might in some cases want to not only social distance, but if you have to pass them in any way, you might want to wear the mask for precautions. But in general, when you go out into the public, that is when you're going to wear. And where are our battle zones? The grocery stores, the L trains, the buses. You are surrounded with people with whom you don't know their status. And one of the things you're going to want to do is when you get home, carefully, we call it in medicine, doff. Carefully doff the mask so that no contents that are on the surface are just spewing all over the place. Carefully remove it. And if it's at all possible, drop it directly into your into your washing machine and throw it in. Then you can add the rest of your clothes, wash it with some hot water, soap, and then prepare to send it on out to your dryer and reuse it at a later time. For those who don't have the convenience of a washing machine in their home, you can also take that same do-it-yourself mask, put it in a sealed bag, along with maybe your clothes that you wore, when you went out into that battle zone, put those in there as well. And when you have an opportunity, carefully remove those clothes and launder them. So yes, to answer your question, please wear a do-it-yourself mask or a mask. Don't wear the N95s. Don't be out here taking all of our masks that we need in the hospital. But any mask that you have, believe me, it will be helpful. It would definitely be better than none, for sure.
And yes.
Okay, thank you.
Yeah.
Oh, go ahead.
Excellent.
Go ahead.
And I was, just like Dr. Conway explained, and that when the CDC added the mask recommendation to help protect, or to at least, like she said, assume you have it and you're protecting everyone else, and it may protect you also, but also that it does not, it is not a substitute for hand washing, all the stuff we talked about a month and a half ago when masks were not recommended. Hand washing, soap and water, 20 seconds at least, hand sanitizers, and social distancing. Staying away, staying home, staying home. And if you have to go out for work or to buy groceries, we'll talk about that. But that the biggest thing anyone can do as a person living in the world right now, not just in the US, and we have most of the cases in the world right now, is to stay home. When the history books are written and you say, we survived this, what was your role in it? Staying home saved lives. Staying home saved, people who are vulnerable in your community, people you didn't know. Staying home saved the lives of healthcare workers. We have healthcare workers who are infected, who are dying. Staying home by saving their lives, save the lives of other people. So if you have to if you have to give yourself a tiara, a crown, a sash, that during this, when they asked me to stay home, I stayed home and I saved lives in the history books. Yes, you did. You did, and you did. It's really important. So the masks are not a substitute for not staying home. They add on to keep helping, because the numbers kept going up, and the CDC said, we're already social distancing, we're hand washing, numbers are still going up. Let's try and do some more control. So it's in addition to, so we don't want people having their masks on and then hanging out with everybody else. That's not the point. I think we lost our host.
Can you hear me, Dr. Toyin?
Yes, I can hear you. I don't see Dr.
Okay.
Rene.
Again, I'm having a few technical difficulties, but I'm glad that you can hear me until Dr. Rene comes back. But one of the things that I wanted to talk about is 10 tips to staying healthy. Staying healthy during this COVID-19 crisis. And I'm going to go through some of them a lot quicker because they're ones that you already know until Dr. Rene makes it back. But here's some of the basics. Number one, continue to physical distance. They're now using the word physical distance preferred over social distancing, because social distancing acts almost like we can't connect in any kind of way. So continue to physically distance yourself at least 6 feet.
Yes.
I know Dr. Toyin can talk a little bit about whether or not, there's a big raging debate even in scientific communities, whether or not there's a bit of aerosolization of this. Obviously there is, when people cough, and the immediate effect of that is that the particles are out there in the air. And, if you happen to walk away, it's going to take some time before they can actually fall down to the ground. So yes, they're out there. So keeping a physical distance gives you, time buys us a little bit of space and, a little bit of additional safety. That's super important. Wear your face mask. We talked about that as well, especially when you are out in public, when you are out in the stores. I was talking to someone actually today, that going to stores sometimes feels like you're in the middle of the Hunger Games. You need to be careful when you're going out there. So that brings me to a couple of other points. Shelter at home. So I know everyone, we talked about, we will talk about, a little bit more about the disparities and why Blacks and Latinos are dying the way they are. But part of the reason is they can't shelter at home. Many of them are a part of the essential work group. They are paramedics, they are first responders in other ways. They're firemen, they're police officers. And when you look on television, they're dying. So this is not a joke. You need to stay home if you can stay home, because people are dying so that you can stay home. So I wanted to make that point, and that's concerning. A lot of our people of color don't have the luxury of riding in their own car and taking a quick little ride just to get some air, but still stay away from everyone. They're actually on the bus and on the train. So just want to remind you, if you have that privilege to stay home, you should definitely stay home. And then I want to talk about this is number 4, avoiding non-essential travel. I really want to make a point of that. I think some of us have lost, the aspect of what it really means to shelter in place. And when we say that you can stay feet away from one another, we saw that Mayor Lightfoot had to actually shut the beaches down because people wouldn't exercise what, in my mind, was common sense. But they always say that common sense is not always common. We have to avoid non-essential travel. So what is essential, you might add? Going to the grocery store. When you go to the grocery store, I highly recommend that you try to limit your visits. If it's possible to space out your visits to every 2 weeks, every 3 or 4 weeks, limit your visits so that you don't have to go in there. There's tons of people in the store. It just cannot be avoided. Some things that are not essential, getting your nails done, getting your hair done. There was a barber that was recently, it was a very sad story in Brooklyn, who was doing house calls. And I get it, this is the reality of what people are dealing with. But barber work is not essential. And though he lost his life, other people could potentially lose their life just because he went over their homes. So that's not essential. We got to be creative. I think as people of color, we have long known how to be creative. We learn how to do our own hair in the house. We know how to do our own nails. We got to remember what is essential and what is non-essential. So please, groceries are one. Some people talk about going out to eat. I know we're trying to protect our restaurants so that they don't go under. And we could talk a little bit about how, if you're going to buy food out to go, how to try to do that safely. Another thing that I think that is very important to stay healthy, please exercise about 30 minutes a day. I can't emphasize to you enough how important it is. Not only, as Dr. Toyin talked about the BMI, and how a great majority of the people who have died or suffered greatly with this disease have been overweight with high BMIs. Of course, it's not all, but it's quite a few. Now, your exercise may not help you to lose weight quickly, but one of the more immediate benefits of exercise is the increase of endorphins. You feel good. Cardiovascular is great for your heart. There's a lot of healing properties that begin to develop after you complete exercise. So there's 1,001 reasons to do it. So please do it. We talk about don't allow being at home to make you get fat and overweight and be make poor habits, poor decisions in terms of eating. Like saying I'll eat all of the whatever I want, all of the chips and cookies and cakes and all of that. So be careful about your eating. Try to eat healthy, vegetables when you can, fruit when you can. Another one I want to really talk about, because I don't know about you, Dr. Toyin, and I know I can't hear you, so I just got to talk until I finish this little short list. But one of the things that has been a saving grace for me has been meditation. Yes. I have struggled. This is very depressing, not just for you all, us doctors, and especially the doctors and the nurses and the respiratory therapists who are watching people die. This is the most stressful time, I think, that as a physician, I'm sure myself, Dr. Toyin, and Dr. Rene, there's nothing that is comparable to this. No. And it has a way of really just taking your literal breath away. And if we fall, there will be no one there for you. So one of the things that I recommend for doctors, for any of you who are out there struggling with this, there is an app called Calm. I'm not getting paid by them. There's other apps out there. You can even do this on YouTube. Start exploring meditation. Taking a good 20 minutes in the morning to meditate, 20 minutes in the evening to just steal away, be quiet, and then just to rest. And like I said, there's apps like Calm where they'll actually teach you to meditate. Of course, we should always pray. And that is a different type of focus than meditation. Meditation is more about stealing away and trying to shut down all of the impulses and just kind of quiet your brain. I think both are very important. The next thing, number 8, disconnect from the television and from, even media like this. We're trying to give you important information, but you do have to pick and choose and be very careful and protective of your spirit, because a lot of times this can weigh heavily when you're just getting this 24 hours a day. Yeah. So set a stop time that you're not going to be on the internet, because believe me, when you wake up, you'll get all of the same information. You'll find out what Trump said. You'll know what Mayor Lori Lightfoot and Governor Pritzker said. It'll all be there on the next day. So unplug. And then the final last 2 things I wanted to say is try, in terms of the 10 steps, is try some fun stuff. We got to become creative. Like I know some people that are doing online Zoom parties. Yes. I think there's a way to do it. The Clark sisters are going to be on this Sunday, and I plan on having a Zoom party so we can watch this. My favorite ladies of gospel of all time. And so those things are important. They have online bingo, things that you can actually interact with other people without touching them. And the final thing that I like to say in terms of as it relates to staying healthy is just to remember that trouble doesn't last always. We will get through this. We have to stay positive. Super, super important. And Dr. Toyin? Wow. I would say until we're able to get Dr. Rene back, we are both former and present hosts of Medicine Makers. Yes. We will talk about some of the things until Dr. Rene comes back. So go for it, Dr. Toyin.
But I mean, your 10, I was taking notes as you were writing, as you were saying that, and writing them down, and that is so critical, because for you brought up things for your physical body, for your mental health, for your spirit, and just not giving up hope, because when you look at the numbers, and it's overwhelming, and to be able to say, well, we'll get through this, and what can I do now, and what behaviors am I going to carry over when things end? So when we talk about social distancing, physical distancing, and a lot of outbreaks they've traced to family gatherings. So people felt like, okay, we're not doing big things, but we're getting together in small families, and outbreaks. They had the outbreak they published in Chicago, where one person came to a funeral, shared takeout with a couple of people, and they went to another birthday party. Yes. The Chicago group, one person with a mild cold. If he was feeling very sick, he wouldn't have come. Very mild cold symptoms. And by the end of that, 16 people were traced to him. 3 of them died already. A lot are still in the hospital, just from one person with a cold. And that's why with this virus, up to, they're thinking now 25 to maybe even 50% of people who are shedding and spreading it have no symptoms, which is why when you go out with the mask, pretend and assume you have the virus, and that you're protecting grandma, you're protecting your 25-year-old neighbor with asthma, you're protecting the healthcare worker who's going to take care of your wife who's about to have a baby. I mean, people still have to go to the hospital for emergencies. So it's really important that this social distancing and physical distancing includes staying away from family members. It's hard, but connect with them virtually, do the Zoom, Skype them, share information with them. So some people don't have internet access. They get so much information. If you have good tips, you have good information, share it with them. You don't have to see them. You can show people you care about them by reaching out, sharing information with them. If you know tips about things that are important, it's very important, because when people get sick, and you've been in the hospital, I'm not in the hospital anymore right now, but when you talk to my colleagues and the healthcare workers, respiratory therapists, like you said, people, once they get admitted for COVID, even when they're being suspected COVID, they're in isolation right away. No visitors in the hospital for anyone. People are doing this alone. They're scared. They go on a ventilator, family members. So if you think about it, avoiding that little family gathering, birthday party, Easter celebration, you're saving somebody, because a family member who gets sick from this is going to be in a hospital alone, not even able to see or touch anybody. So we need to really think about it. 20-year-olds can't be out there playing pickup basketball. There's a meme by Lori Lightfoot that's like, she said, there's this meme that says, your pickup game, your shot is always going to be weak. Just stay home. I mean, stay home, because these are the things that you're doing to protect people you know, people you don't know, and the healthcare workers who are needed. You brought up the essential workers who have to be advocate for them. We need to advocate for them to make sure that they also get the protection that they need. The people who are at the grocery stores, stocking the pharmacies, doing our delivery, still doing our mail, that they get the protection they need. The first line responders. We've had a lot of deaths at O'Hare, of baggage handlers and people who are still out there. So it's important to know that some of these essential workers have to be out there. They have to protect their families. They have to but when those of us who can stay home and telework, figure out how we can, give back and donate to hospitals and do things like that, because there are people who have to be out there. And for everybody else, please stay home. That's your part in doing this stuff. And knowing that when we have good information, to share it, share those tips, reach out to people who we know need help, share information with them. But also, when we talk about information, also, if there's stuff that's going on that seems like it's a rumor, that is false information. I mean, I have to be honest, the rumor that was going on 4 weeks ago about Black people being immune or protected from COVID, this was about a month ago. This was going around in the internet. I think that allowed some people not to take this seriously for a while, because it was like, oh, there are no people, Black people dying of this. And by the time it started to happen, it was already in the community. So not sharing false information, because there's some information that you share that only hurts one or two people, hurts you, and everybody knows this is not right. But some information that is shared that is misinformation has the ability to penetrate. And 3 weeks later, we're playing catch up, because people had thought this doesn't apply to me. So it's important to find trusted sources of information. If you don't trust the federal government, you don't trust your governor, whatever it is, figure out who you trust, get the right information, so we don't have to play catch up in our communities. So I think
I apologize for the delay, because again, I'm not hearing, but I'm trying to do a little lip syncing and reading lips here. But I want to ask a couple of questions, and I'm going to throw these out and to Dr. Toyin. I think these are some great questions, and I'll just try to look at it when you're finished talking. Maybe you could throw me a peace sign, and I'll ask another question. We could go maybe that way. So Randall McFarland, he is one of the administrators over the Proviso Township group. It's a wonderful group that addresses many of the needs of the Proviso Township, which is Broadview, Maywood, Bellwood, and just been a pleasure interacting with him. He's online, and he wants to know what are the percentages of African Americans. I think he means overall, that are not having access to the coronavirus test versus other communities, particularly in the Chicagoland area. And do the doctor's determination that someone doesn't fit the criteria for a test, matter? Does this reflect any racial profiling? I think that, just to piggyback his question, when you look at the testing sites in Chicagoland, they're a little bit disturbing. They're only in certain locations, and they're finally getting them out to other places. But surely I do think I know what he's talking about. For a long time, we were talking about, 3 big symptoms that people had to have. And you have already aptly said that this virus presents in a myriad of ways. And in the early months, we were basically being instructed that if you don't have a fever, if you don't have shortness of breath, and you don't have a cough, it was that triad. Don't even bother anybody, because you're not going to get a test. Thankfully, we now know that there's a myriad of symptoms we'll let Dr. Toyin talk about. But at the same time, can you comment on why do you think we don't have testing in certain neighborhoods? There's a limit of testing for sure, but why certain neighborhoods don't have them?
So, first of all, as the whole United States, we were way behind on the testing. I mean, literally, as of a couple of days ago, we had done maybe 2 million tests, which seems like a lot. But in a population of over 300 million, you can see that we still haven't tested. The countries that have done the best jobs have been able to test a larger number of their population. And even now, with those 2 million tests, a lot of it is still priorities, right? They're still like healthcare workers, because we need to know, because if healthcare workers are infected and they're taking care of people, there's a, of spreading the virus and all that. People who are symptomatic, who are ill enough in the emergency room, who need to be hospitalized. There are people who in other parts of the city and country where even if they're sick, they come into the hospital, they think they have COVID, they're not enough tests. They're like, well, if you just have a low fever, you can go home and we just assume you have it. So, the tests, we have such a shortage. Now there are increasing tests, right? So initially when we started testing, like in Chicago, everything had to go to the state lab. You had to fill out all these forms to get it to the state lab. Turnaround was like 4 or 5 days. Then all the commercial companies, LabCorp and Quest, came on board. That increased it. In the last 2 weeks, there have been new tests now, an Abbott test that you can get the results within 15 minutes. There's a platform called Cepheid. There's all these tests that have come on board, which is that Illinois is doing. In Illinois, we're now doing 5,000 to 6,000 tests a day. I mean, at one point, that took us a week to get 6,000 tests. So it is ramping up. You're right. If you think about when those tests came up, initially they were in big hospitals, right? And then in big, large academic hospitals. And then even those labs that could do it were labs in clinical settings, in big hospitals. So like major hospitals could get the testing, they had the platform. So if you think about communities where there are no hospitals, right? Shortage of hospitals, very small clinics, primary care clinics, those providers didn't have access to tests at all. And if you look at where the testing locations were, even when they started to do the drive-through testing, a lot of them were in the suburbs. They were in different areas of the city. So you're right, whoever asked that question, we had fewer testing sites. Most of them were in big hospitals initially because there was a shortage. It was triage to people who had come into the emergency room. And we had already told people, if you're ill, stay home unless you're really, really sick. So people stayed home. And even when people came into the emergency room for a while, not everybody could get a test. And yes, there have been reports of people reporting that they were denied testing until the third time when they were really sick in the emergency room, that they had gone into their doctor's office, they had a fever or a cough, they were denied testing. So yes, there are disparities in access to testing, in biases on who gets testing. And even when we actually started the drive-throughs, there were drive, which means you drive your car to a place, because it was a way to prevent people from gathering together, so people could be in their car, the healthcare worker could be done, and they do the swab and you move on, so you're not exposing other people. What if you don't have a car and you're in public transportation? So you couldn't get a test, right? So there were all these reasons why people of color didn't have access to testing. It wasn't in their communities. They were told not to go to the emergency room, stay home. They were told, call your primary care doctor. Well, if you don't have a primary care doctor, who do you call, right? If you have a primary care doctor, you knew who to call. They'll do a telecall. So no primary care doctor. You were told not to go to the emergency room. There were no testing sites in your community. When you did go in to see a doctor in your community, your doctor didn't have testing kits in their sites. They were restricted to the big hospitals to validate it. And then when you could do testing in the tent, you had to have a car to go through the drive-through. So all of those reasons contributed to people not getting tested on time. And then when people had symptoms, they were told to stay home or go to the hospital if you got sick. Well, people were coming to the hospital really late because they were scared to go into the hospital. And then they didn't know what when you get sick means. If you already have a little bit of shortness of breath from your heart failure or from your asthma, and you're short of breath, you don't know, is this COVID now in your lungs, or is this your asthma because you don't have inhalers? So people of color, when they were getting to the emergency room, a lot of them were more likely to get right from the emergency room, very critically ill, have to go on a ventilator in New York, in places like that, as opposed to somebody who had a primary care doctor who tested you, sent you home, and was doing a check every 2-3 days to say how you're doing, which is what you do when you send people home. So for all of these reasons, plus we talked about all of these other medical issues and crowding, right? So we talk about multi-generational housing and people living with a lot more people in their space. So even if one person had symptoms, right? And you said, stay home, just check your fever, they were back home with 4 or 5, sometimes 6 other people sharing the same space. It was hard to isolate. So bottom line is, yes, there were disparities in every aspect, which is why we have to take this seriously. We have a high rate of the medical problems. We have lower rates of access to testing. We have all of these issues, and then more likely to be outside because we still have to work. And you put all of that together, it's a perfect storm for bad outcomes. And that's why it's important to talk about the physical distancing and how to remain healthy, those top 10 tips to do our part as we continue to advocate for those changes that need to happen.
So thank you, Dr. Toyin, and thank you, Mr. Randall McFarland, for that question. I want to let you know that you are watching a live event for Medicine Makers, usually produced by our executive producer, Dr. Rene Roberts, who had some technical difficulties, and she is also one of our main hosts. But you are left in good hands with two Medicine Maker hosts that are here on board. And we got Dr. Sweetie Conway and we got Dr. Toyin Adeyemi. And for those of you who missed our earlier introductions, this is my good friend for over 25 years. We try not to say those years too often, but it's been a long time.
And we were already
We started medical school at
met.
5. I told you about that. We were very, very smart. And so now we are here. So we thank you guys for joining us. We have a couple of other really good questions. I've got some thoughts about this one. I'm going to toss this one out to you, Dr. Adeyemi, and let me know what you think. There is a young lady by, let's see, did I lose this one? I'm sorry that I'm not being able to get your name, because if I see it, I'll shout you out, because we're so thankful for you joining us and sharing in this information session. But what she wanted to talk about, which is a great question to me. As we know, the sensitivity of these COVID tests, and maybe you guys don't know that, but these are not the best tests in the world, okay? The sensitivity is not that great. And there's a lot of factors that affect that. Sometimes it is the way that the person who's doing it, so it's an operator error. They may not get the swab. There's 1,001 reasons in between why sometimes you've heard these stories of how people went back and forth. They were very persistent and they were constantly told that they were testing negative, yet they were getting deathly ill. And maybe while they were intubated, they got re-swabbed, and then they were ultimately found to have COVID, which they had all along. So the question was, and if I find her name, I'll mention it, but she wants to know, what do you think about the antibody test? Mm-hmm. I know that there are companies, again, not being paid or promoted, like Vivera, who had reached out to me earlier in a couple of weeks back. And they have an emergency use authorization, very similar to the EUAs, as they are called, for Abbott and other places as well. And they're very promising, especially in certain facilities in congregate living, for example, like nursing homes, where you're really trying to figure out who might be COVID recovered, who who seems like they may still be in the midst of active illness. Has a lot of utilities, but I was wondering to get your thoughts, especially as an infectious disease doctor, on what do you think about the emerging antibody tests? And thank you, whoever that young lady was, thank you for sharing that question, or gentleman, thank you.
Yes, I think it is going to be extremely helpful. So like you talked about, the PCR test, which looks for live virus, which is what we use now for diagnosing, is really sensitivity from the nasopharyngeal can be anywhere, in some studies as low as 50%, in some studies as high as 90%. So there's a range on that, and it depends on who's doing it. Are they getting far back enough? Are they do they have, not everybody has a lot of virus up there. And also we know that when people have in the sputum later on, it becomes more positive if they get a bronchoscopy when they're about to get intubated. But those are not things you do for routine screening. So yes, we have had people who had false negatives, and we know already, we know the limitations of some of these tests, that when somebody comes in and has features that we think are suspicious for COVID-19, even with when the results come back right away, you tell them, go home, be in quarantine for 14 days. And even if it is negative, if they fit the symptoms, you definitely tell them that it's probably a false negative. Stay home, don't go out, all of that stuff. So it's important to know that those tests, the PCR nasopharyngeal tests, are not perfect. They're good if they're positive, because you shouldn't have COVID-19 up in your nasal but if they're negative, it could be a false negative. The antibody test is a blood test, and there are a lot of them that are coming on board. I mean, they're going to be approved. Some are approved. They're getting emergency authorization, and those look at antibodies that can tell you if somebody has an acute infection, and sometimes to see if somebody has been exposed. So because that antibody test, the IgM, which is the early antibody that goes up, it goes up around the time when people have virus. But again, it can be negative early. So if it's done too early, when somebody is just starting to have symptoms, they don't start to go up until about 4 or 5 days. So you could miss it and tell somebody they're negative. So now they do say if you combine the IgM, which is the early, and the PCR, which is the nose thing that you do, then you can get to really high, over 90% sensitivity, because you're using blood and nasopharynx, right? But I think where those tests are going to be very, very helpful is the IgG, which is the one that tells you if you've had the infection, right? So everybody who's had positive COVID-19, the ones who've been diagnosed know they have it. That's great when they recover. But the IgG is going to be for that. We talked about 25 to 50% of people who are shedding this virus who have no symptoms. If at some point we can find out who has had the infection in the past, it will help us to know who is immune, relatively immune, who can go back out into the workforce. It will help to know healthcare workers who can be back at work. It will help us to know as a community when we start to see who can be out there who's had the infection. It will also give us a better idea of how many people had this infection that we didn't even know about. So they're coming on board. There's IgM testing. It will be one test in the blood that will check for IgM, which are early antibodies, and IgG, which are later antibodies. And one of the reasons that would also be helpful is that when we start looking for people who may be donors for plasma, which is a therapy that is becoming increasingly used for severe COVID, to give blood plasma from somebody who's recovered, it would also be a way to know all the people who have had COVID, who have antibodies, who will be good donors for plasma. All right. So plasma therapy is one of the things that will be that is being used now. So those antibody tests are not great by themselves, but when you combine them with PCR, and more of them are being looked at. It looks like there's about anywhere between 8 to 12 companies that are coming on board with antibody tests for COVID. Oh, so Dr. Conway just told me she lost her volume. I think I can see.
Dr. Toyin, can you hear me?
Now I can, yes.
Can you hear me, Dr. Toyin?
Yes, yes.
Perfect. Okay. I don't have any video and I can't hear any audio, but you talk about trying to make the best. So I wanted to share another question, which I think is important. Someone asked, and I don't have my mask handy, but someone asked about proper use of masks. And we did talk about do-it-yourself mask earlier, but I just want to emphasize, I have seen people doing the most comical things with these masks. They are really just funny. I just want you to know they're not helpful, though, not in the slightest bit. So again, we talked about the do-it-yourself masks, which are fantastic. I think any barrier is better than none. But you know what? No protection works unless you wear it. So I've seen some people who are walking around and they'll have the mask underneath their chin. Not quite sure what that little arrangement is about. Not good. I've even seen people, strangely, take the mask and it will be just kind of over the nose, and both the nose and the mouth are out. So just want to encourage you and remind you to take time to place the mask properly. And if you have something that where you can actually kind of secure it around the nose and press down a bit, that would be actually ideal as well. Well, make sure that you are wearing your mask where it can actually keep you protected. Again, you got Dr. Conway and Dr. Toyin, and unfortunately, I'm not. Perfect. She came to show us. So, Dr. Toyin, can you show us some of the wrong ways that people are wearing the mask, possibly?
This is one of my homemade ones, and I did the whole, the bandana one with with rubber bands because that's easy. I'm going to try and do some sewing this weekend. I haven't sewn in a while. I'm going to do some, but this is one of those self-made ones, and I'm trying to use like really cool fabric so I can jazz it up each time. And the good thing about the cloth ones is you can wash it yourself. But again, the main thing is the tie ones you talked about, the way you tie and tie. This is a rubber band one, but you want to make sure it's covering your. Again, I'm only having my hair out because I'm doing this thing. When I'm anywhere out, put your hair. You don't want any kind of just having to touch anything because it's not worth it. This is the time to just be not glamorous, but you want to cover your nose and mouth are covered completely, right? Some of the ways we've seen people wear it is like this. I've seen people like the chin thing. I don't know what this is about. We've seen people wear their chin. I've seen people wear it just covering their nose, right? Or covering their mouth. It's to cover the places that the virus can get to. And then if you have, some people are making it with a little filter, coffee filter in the middle to add more protection, or add a little, I don't know what, the pipe fitters that people had, so that you can have a seal over your nose. But what you don't want to do is have it on and then be touching your eyes and stuff, because this virus has caused infection through the eye. It can, anywhere there's mucous membranes, it'll do that. So you want to make sure it's fitting and it's covering your nose and your mouth, and that it's tucked in, and that if you use the tie one, you take it off that way first and take the bottom one and make sure that you wash it, because you don't want to keep, and then don't, if it's been out there, don't put it in areas where, so yeah.
Now, thank you, Dr. Toyin. Again, I'm working at a deficit, can't hear, but for those of you who are joining us in late, I want to let you know I'm Dr. LaMenta Sweetie Conway. We lost our host, Dr. Rene Roberts, but she'll be back on our next live event. And I am accompanied by my good friend and fellow board member and friend from way back when, Dr. Toyin Adeyemi. She's an infectious disease specialist. And we have a couple of more amazing, these questions are good. I want to give you 2 questions because I can't hear you. But hopefully, and you let me know when you think that we need to bow out. I'm thinking that maybe by 8:30 we probably need to call it a day. We want to get in a couple of these really good questions. Karen Green from Maywood asks, the question that I know we all want to know the answer to. And I know you're not going to have an exact answer, because that really depends on what Illinois decides to do. If they're going to shelter in place, or if they're going to keep their butts at home, or are they going to rip and run? And with this warm weather, are they going to be out here not following the mandate? Are they going to be not social distancing? That's going to be the answer to Miss Karen Green's question. But if you could make a projection, I'm going to give you this question first, and then when you're done, just give me a peace sign or something. The first question is from Karen Green. When do you think Illinois is going to reach its peak? Which is a great question. And then the second question is by Melissa Wandik, and she wants to know. I'm sorry. I will get to Melissa in just a moment. Her question is actually a very good one too. Should people who are positive isolate together? I can tell you the answer to that. Yes, if you're positive and you're in the same family, yes, stay out of all the rest of our way. It's a great idea, and there's no problem with that. You can't go wrong with that in general. But there was another question, and I can't see who actually asked it, but someone wants to know whether or not you can be reinfected. That is a concern for people. Again, Dr. Toyin is an infectious disease specialist, and we're going to let her answer. When do we think Illinois is going to reach its peak? And are we concerned about any other strains of COVID? I understand there might be about 8 different type of similar strains of COVID. And so this may be going on for a minute or so. Tell us what your thoughts are.
Yeah, so I am one that I listen as much as I can every day, if possible, or on replay on Facebook to the governor's press briefings, because he does that, and he does it with our amazing Dr. Ezike, the IDPH chief, who they talk about the numbers, they talk about initiatives and things that they're doing. They look at the models, and then the mayor's office also does their briefings, which are really good too. from their projections, right? The social distancing has worked. We're definitely better than where we would have been if we didn't go in shelter in place in March. But definitely based on in that initial part of March, right? The social distancing has worked. I hear my phone better again. Than where we would have been if we didn't go in shelter in place in March. It's definitely based on in that initial part of March, right? If we hadn't done that in that initial part of March, we were seeing cases double every 2 to 3 days in Illinois, and now it's much lower than that. The rate of rise is much lower than that, which shows that people are staying home. Not everybody, but according to their most recent projections, they think we could reach our peak within the next couple of days, as early as next week, like April 15, 17, that we could reach our peak in Illinois, where the number of people who are hospitalized and diagnosed are at the highest, and then we start to go down. What that means is that, yeah, we reach our peak. It doesn't mean that they're going to release the restrictions or going to open up anything. It just means that maybe we finally got into everybody who stayed home, everybody who was incubating, their 14 days are up. They're now in the hospital. We've been tested. And so our peak could happen by next week. And then what happens next would depend on how things go and how those numbers come down. And there is no plan to reopen anything for a long time. I don't know what those numbers are, what those dates are, but I know that sheltering in place, staying at home, has helped Illinois lower than where we would have been if that hadn't happened in March, on March 21, I believe, or March 20th. And that our peak by projections could be as early as April 15 or 17, and today is the 9th. So we're getting there. But then after that is just kind of the beginning of, well, what happens next after that? The second question about reinfection, there have been case reports and cases reported of people, mostly the case reports, I think, from South Korea, case reports from other places, very small numbers of people who may have tested negative and now are positive. And is it a reinfection? A lot of the belief is that most of this has to do with maybe a false negative test. So is it possible that those people were tested negative because we talked about how those tests are not perfect and don't have a lot of virus? The test could be negative if it's not collected properly. So for those people who had COVID and had a negative test and then had a positive test again, is it a possibility that those negative tests in the middle were false negatives? The question is, why were they tested again after they had been negative? Did they have new symptoms? Were those new symptoms from something else? So those are still very few and far between, because what we believe, at least at this point, is that if you have the virus and you recover and you have antibodies, you should not be reinfected. But again, this information is new and emerging, and we'll continue to follow that. The question about, what was it? The other question about the strains, yes. So when the strain that was circulating in Italy was thought to be very different from the original strain in China, and now it looks like there could be up to 8 different strains with minor variations. Now, they don't think those minor variations are going to be really impactful in terms of making a vaccine. So just like the regular seasonal flu has strain changes from year to year, we're still usually able to make a vaccine for the flu. Some years there's a good match, some years there's a better match. There are different strains circulating, but the antibody that is produced to coronavirus 2 should protect against strains that have minor alterations. So hopefully that answers that question, that we really don't know for sure that people can be reinfected because they should have protective antibodies. And it's possible that those people that may have had a negative test and then a positive one could have been false negatives. But that's something that's been looked at. And Sweetie is gone and Rene is gone. So, okay. It looks like I'm the only one left on there. Okay. Okay. All right. So I'm texting. Okay, so I'm going to end the live stream. Dr. Rene says she will be doing an after, and I'll end the live stream and get off now. Okay, so thank you for listening. I'm going to get off now. Hopefully we answered your questions, and all right. Thank you.